to talk about non-steroidal anti-inflammatories, DMARDs, and the disease pathogenesis, or part of the disease pathogenesis of RA and gout. All right. So learning objectives, there's a lot because remember there's 3 topics that are covered here, so they're all essentially on this slide. Kind of a summary drug list, basically just demarcating the differences between these different drug classes. Okay, so let's start with Nsaids. So remember back to your signs and symptoms. You know, the classic descriptions of inflammation are old. They're referred to the cardinal signs of inflammation. And essentially it's heat, redness, swelling, pain. Those were the original 4 cardinal signs. And then a couple centuries later, they decided to add the descriptor loss of function. So that's depicted here by these ancient Roman or Greek symbols depicting calor, rubor, tumor, dolor, and loss of function, functia lassa. So these are your non-steroidal anti-inflammatories, and these are essentially the different targets of these anti-inflammatory medications. And you're familiar with them. I mean, Advil, Tylenol, aspirin, Excedrin. I've never heard of Bufferin or Goodies. I don't think I would even take anything named Goodies. But you know, these are the drugs that essentially everybody's familiar with, but a lot of people kind of forget how they work. And actually, if you really want to do a literature search on, you know, updated pharmacology on some of these drugs, it's not as easy as you'd think. I think we kind of take it for granted as to how these things work. But you know, understand some statistics. You know, we spend a lot of money on drugs as a group that can essentially treat different aspects of pain. This particular figure is from 2010, summarizing sales in 2009. I couldn't find a more recent one, but basically we're at about $30 billion worth of money that we're spending every year to alleviate pain, and of that, about 1/3 of that is spent directly on NSAIDs. You know, so this is a very popular drug category and something that you should know about. All right? So understand that the way this whole inflammation process works centrally starts with arachidonic acid. All right, and so arachidonic acid gets converted into prostaglandins, and that's through 2 related enzymes called COX-1 and COX-2. And the outcome of these prostaglandins drives essentially inflammation, pain, and swelling. Okay? On the other side of this diagram, remember the lipoxygenase pathway essentially drives leukotriene synthesis, and leukotrienes essentially govern cytokine release, leading to inflammation, pain, and swelling, but also in the disease states of asthma, COPD, infiltration of cells within the respiratory tract. You know, these are all of these different drug classes that are essentially related to combating inflammation wherever it is in the body. So let's start with cyclooxygenase. And so prostaglandin GH synthase, also known as PGH synthase, is essentially a 2-enzyme system. And essentially what you're doing is converting arachidonic acid into PGG2. Okay? So the way in which this occurs is through COX-1 and COX-2. The old terms, if you have a old textbook lying around somewhere, PGH synthase 1 has now been renamed COX-1, and then PGH synthase 2 has been renamed COX-2. And that's essentially what we describe them as, but just a little bit of nomenclature background if you see it somewhere. So what's the difference? COX-1 is found in blood vessels, in the GI, in the mucosa, and it's constitutive, so it's essentially found everywhere, and it's always turned on. And this is the one that basically drives the role of prostaglandins in the normal kind of physiological process. This is in contrast to COX-2, which is essentially found in macrophages, other immune cells such as mast cells, and these are associated with that, you know, acute inflammatory immune response. And remember, the COX-2 enzymes are inducible. Now, so the way I remember it is, you know, how many of you are the firstborn in your family, right? Me too. So the firstborn people are perfect, right? The second-born and so on, they're the Me Too generation, right? They, you know, oh, my older brother, my older sister's a doctor, I want to be one too. So those are the ones that, you know, Me Too, inducible, you know, that's how I remember it. Yeah, but if you're firstborn, essentially you're perfect. Don't let anybody tell you otherwise. Okay. So we can't talk about inflammation without talking about aspirin again. So at this point, I mean, we've talked about aspirin several times, right, throughout this whole lecture series in pharmacology. But we're going to talk about it in a kind of a different sense that hopefully will put the nail on the head for many of the concepts that you've kind of heard about, but now need to understand because we're running out of time. So aspirin is acetylsalicylic acid, also known as ASA. Here's the chemical structure shown on the right. It is a natural product, you know that I'm interested in that. I think that's kind of cool stuff. It's a plant extract from the bark of the weeping willow, shown there. And we've started extracting aspirin from these plants since about 400 years before Christ. So this is an old, old drug. So how does it work? Well, mechanistically, it's an irreversible inhibitor of the COX enzyme, okay? Essentially, both COX-1 and 2, we'll talk about more about that in a little bit. And the way it irreversibly inhibits this enzyme is acetylation, okay? And so here's your, where's my mouse? It's floating, oh, there it is. So here's your cyclooxygenase enzyme. This is inside of a platelet, okay? Understand that the arachidonic acid goes into this enzyme component. Here's the catalytic site, and it spits out PGH2, which gets converted via COX into thromboxane A2, and that essentially activates platelets, okay? So the catalytic site is associated with serine 529 in terms of its structure. When you add aspirin, which is shown here on the right, aspirin acetylates that serine residue 529, so it fits in that little pocket, and as you can see here, arachidonic acid goes in, catalytic site is basically obstructed, nothing comes out, okay? And this is the mechanism of action of aspirin, okay? So the outcome, yeah, we're going to inhibit, when we supply aspirin to this enzyme system, we're going to inhibit platelet activation, okay? And that's the benefit, the therapeutic benefit of aspirin when you think of like STEMI and stroke, you know, and being what's called a platelet stabilizer. Also understand that biologically, aspirin can be converted into salicylic acid, which offers reversible inhibition of COX. And so this mechanism that we're talking about here is irreversible, okay? And that sticks around for the life of the platelet, which is, what, about 8 days, right? There's another modified biochemical reaction offering reversible inhibition through a different pathway. And so that salicylic acid part that offers reversible inhibition is this moiety right here. And this red moiety is the one that offers irreversible inhibition, okay? That's overkill, but I mean, now you know, all right? So we said there's two enzyme systems, COX-1 and COX-2. COX-1 is what's considered the constitutively expressed enzyme, and COX-2 is the induced. Well, the COX-1 metabolic pathway basically begets homeostatic functions. And so these are the things that we think of our classic aspirin targets. You know, the GI tract is basically a side effect. Platelet function and macrophage differentiation, these are essentially your cardioprotective properties. Low-dose aspirin, okay, essentially targets inhibition of COX-1, and we'll show you why in a minute. And low-dose, what is low-dose aspirin? It's shown here in red. It's all matching. 70 to 80 milligrams is considered your low-dose aspirin, and that's what we see in the cardioprotective studies. Remember when we talked about that clinical trial that said, you know, high-dose aspirin therapy post-STEMI doesn't really offer therapeutic benefit, but the low-dose aspirin therapy post-STEMI offered tremendous therapeutic benefit, and that's why patients take low-dose aspirin. High-dose aspirin, and by high, I mean up from 600 milligrams to upwards of 4,000 milligrams, we can inhibit COX-2. And COX-2 is the pathway that, remember we said it's inducible, but it's the pathway that drives inflammation, and that is the outcome of the analgesic properties of high-dose aspirin. Okay, so if you increase the dose tremendously, you can essentially target pain management, and that's why aspirin belongs in these series of lectures. Now, if you don't believe me, here's another diagram depicting COX inhibition with aspirin therapy, and here's your 81 milligram, this black line. And here, look at this. We've got essentially, 90 to 100% inhibition of COX-1, which is shown in red. And we've only got about 40, 45% inhibition of COX-2, which is shown in black, okay? Now, some could argue, well, you said milligrams, right? And this is micrograms per ml. This is in vitro. This is an in vitro assay. If you want to extrapolate it, micrograms per ml can be converted to milligrams per liter. It's the same mathematical relationship, all right? So what do we use it for? Well, you know some of these. Aspirin, remember, is the prototypical NSAID. It is a platelet inhibitor. It's going to be used in management of patients post-STEMI or stroke. It can be used as an analgesic in acute pain. And the type of pain that it typically targets is the mild to moderate muscular or skeletal pain. Okay? You can use it in headaches, specifically tension headaches. And we know that aspirin is a great antipyretic. You can use it to treat fever, all right? But you never ever, right, give it to children with well, you never give it to children at all, especially if they have a viral or a bacterial infection, because that produces a constellation of symptoms called Ray's syndrome, which is dangerous. There's literature coming out that that aspirin can reduce overall cancer risk. And we'll talk a little bit about that mechanism later. And we know that it's excellent in the acute post-op placement management of stents during PCI. And this last point we'll kind of expand on towards the second and third lecture, talking about its anti-inflammatory properties and its usefulness in diseases like rheumatoid arthritis. So overdose of aspirin, ringing in ears, dizziness, ironically headache and fever, status and changes in mental status, and it can also increase the CO2 within the blood. That's going to increase breathing rate, producing respiratory alkalosis, and of course there's going to be a kidney compensation in response to that. So here's kind of a brief summary table of all of the different NSAIDs that are out there. Remember I said aspirin is kind of like the prototypical NSAID, and we'll talk about that. Aspirin, remember we said at low doses is a very nice antiplatelet agent. At high doses, it's an anti-inflammatory agent. Other drugs that I know you've heard of and you've probably taken, even recently, include ibuprofen under the brand name Motrin or Advil. And essentially its uses are pain, inflammation, and fever. This is in contrast to acetaminophen with the abbreviation APAP, which is only used in pain and fever management. I put inflammation on the list so I don't forget to talk about it, and then I crossed it out. Acetaminophen is not officially an NSAID because it does not target inflammation. Okay, I'll say that again. Acetaminophen is not an NSAID because it does not target inflammation. But where else would you talk about this particular drug? So we put it in here as like the one unique drug within that class. If you have friends from Canada, the UK, Britain, New Zealand, you may have heard them describe acetaminophen as paracetamol. Okay, it's the same. Essentially, it's the same drug, different formulation. Naproxen, you've heard of. You've seen the commercials for Aleve. Excellent, excellent anti-inflammatory agent. Not so much with fever and pain. And then understand that, and we'll talk about this a little bit later as well, that there are NSAID combinations. So, Excedrin is essentially acetaminophen and aspirin and caffeine, and that's really effective at treating migraine. Midols, acetaminophen, caffeine, and pyrilamine, and that's excellent for dysmenorrhea. All right. Why do you suppose caffeine would be included in something like Excedrin? Has anybody ever taken Excedrin? Why do they put caffeine in there? What does caffeine do? Well, caffeine is going to change a little bit of the stomach environment. So it can increase gastric emptying time, and it can increase the pH of the stomach. So essentially, any drug that you take with it will get absorbed faster. And so if you're using it for pain relief, especially headache relief or migraine relief, you want that effect immediate, right? And so, dumping a little bit of caffeine in there will expedite the process of drug absorption, allowing the effect of acetaminophen and aspirin to have its anti-pain and inflammation effects. All right? So all of these over-the-counter NSAIDs are essentially analgesics, antipyretics, and offer some anti-inflammatory component. Okay, and so these over-the-counter doses are really intended for pain management and for fever. The inflammatory components can be treated with larger prescription doses. And so if any of you have ever had like a root canal, the dentist may have given you a couple tablets of Vicodin and ibuprofen. The ibuprofen that they gave you was prescription strength. That was like 800 or 1,000 milligrams, right? The milligram strength of over-the-counter ibuprofen is about 200 milligrams, okay? So, the dose of some of these determines, or the size of the tablet determines whether or not it's prescription or OTC. And that's basically just kind of reiterated there. So these drugs are, of course, even though they're relatively safe, they're commonly used, they have effects throughout different organ systems. GI tract has the most common effects, and so all of these anti-inflammatory drugs have symptoms that essentially mimic the side effects of aspirin. All right, except aspirin, in terms of the GI tract and side effects, is actually the most severe. There's a dose-dependent irritation of the GI mucosa that can lead to peptic ulcer in patients that take long-term high-dose aspirin therapy for a variety of conditions. And of course, there's a hematologic component, and that's, again, inhibiting platelet aggregation and altering bleeding time. And that's the use of these aspirin agents, or aspirin specifically, post-STEMI, because you want to inhibit the ability of those platelets to aggregate. Do understand that the prothrombin time and blood clotting time is usually not affected, because you're not really altering the activity of thrombin, and you're not really altering the activity of the other clotting factors within that cascade. Other most commonly encountered side effect or complaint with these drugs is nausea and vomiting. And so, of course, if a patient's allergic to aspirin, there is some structural similarity to some of the other NSAIDs. So, you may want to use some caution when prescribing NSAIDs to patients who are allergic to aspirin. There's been some reports of renal toxicity, even with small doses of aspirin. We'll examine that towards the second or the third lecture, because there's a clinical correlate there. And there's also toxic amblyopia, which is essentially a lazy eye. And there's visual or ocular disturbances that would indicate a need to discontinue drugs, essentially ibuprofen, but others in that category as well have been known to produce alterations in vision. So the anti-inflammatory component, we know all these drugs inhibit COX enzymes, either one or two or both. The anti-inflammatory activity is relatively complex, and it's only beginning to be unraveled and understood. We know that there's a major effect at inhibiting prostaglandin synthesis. We see that when we inhibit the COX enzyme system. The newer mechanism in terms of modulating or inhibiting inflammation, we believe, is coming from inhibition of activating neutrophils. And remember, the neutrophils are the first responders, so to speak, in the acute phases of inflammation. So it makes sense that the neutrophils would be primarily affected in terms of altering the inflammatory cascade that's going to drive pain and swelling. We know that there's a specific group of proteins called selectins and integrins that I'm sure we've talked about or you've heard about in other classes. But essentially, they govern the ability of the leukocyte to roll along the endothelium and adhere to the endothelial cells and then extravasate from the blood vessel into the tissue at the site of inflammation. Okay? And that process is, of course, a prerequisite. And we think that the COX inhibition via these NSAIDs is also altering that activity. Okay? We'll expand on that in a little bit. So these cyclooxygenase blockers, we said they're analgesic, they've got antipyretic, so they can reduce fever, and they're also anti-inflammatory drugs. All right, and these are your NSAIDs. They're non-steroidal in chemical nature, anti-inflammatory drugs. So that's aspirin, ibuprofen, naproxen, ketoprofen. Some of these have specific indications that you can use with great clinical benefit. One of these examples would be indomethacin. You can use that drug to close a patent ductus arteriosus. Okay, you can use acetaminophen, which has analgesic and antipyretic properties. Even though it's not an NSAID, we still put it in this group, you know, to also have that same therapeutic benefit, but not as strongly. And there's also COX-2 selective inhibitors, which were designed to avoid some of this NSAID toxicity that we've been talking about, but that backfired. And if you know the story of Vioxx, you can probably relate to that. We'll have a little correlate within this lecture about that problem too. That was a bad mistake in drug development. So COX-2 was a really attractive target 12, 15 years ago. Remember that NSAIDs as a group have the ability to block both COX-1 and COX-2. COX-1, we said, mediates the production of prostaglandins in the mucosa, and that's cytoprotective. Okay, so if you inhibit COX-1 to any level, you're going to result in mucosal bleeding. That's a side effect we don't want. All right? So we thought, well, let's inhibit COX-2, okay, and we'll reduce the inflammatory distress because that's the one that's inducible, remember? And we can avoid all the side effects of GI bleeding that are mediated by COX-1, right? So logically, that made sense back in the day. So we did. We developed, not we, I mean, I wasn't working on that. I was in college. We developed, I say we like pharmacologists, like we're a secret cult, but we developed COX-2 inhibitors and really potent COX-2 inhibitors. Celebrex binds COX-2 375 times more stronger than COX-1, more stronger. You know what I mean. Vioxx, 1,000 times stronger binding of COX-2 to COX-1. Okay, and so these drugs were originally approved for osteoarthritis, rheumatoid arthritis, acute pain, cramps, and we found that there was a reduction in gastric and platelet side effects. This is great. Okay, but there was cardiotoxicity, and so this cardiotoxicity was not reported in the initial trials. Okay, and so this was kind of crossing the line, so to speak. The next couple of slides has this expanded. But essentially, the trial, which was called Vigor at the time, argued that the cardiotoxicity that was noticed was minor, and it was not. And it argued that the cardioprotective NSAID, which they said was naproxen, was in that same trial. But logically, naproxen isn't cardioprotective like aspirin, and it's certainly not 5 times as cardioprotective as they said it was when they were comparing these two drugs. So I put in an evidence-based medicine correlate. I'm not going to spend too much time on this, but this tells the whole story of Vioxx's demise, starting from May of 1999 when FDA approved Vioxx in the US to essentially November 2007 when Merck decided to pay $4.8 billion, which I think was the largest drug settlement ever, and also did not admit fault and avoided personal injury lawsuits. Why so? 20 million Americans took this drug, and it had, I don't know if I have the numbers in here, but it had a much enhanced risk of heart attack for patients who were on Vioxx. Okay, so, this is probably a good example of what not to do. Okay, a little bit more reading for you through here. You can read this by yourself. But essentially, the fallout from this was that, the COX-2 specific inhibitors were essentially removed from the market relatively recently. In 2005, the FDA asked Pfizer to voluntarily remove Bextra, which is valdecoxib. Celebrex, which you may have heard, is still on the market, but with a very, very stern warning. Okay, so the risk of having a patient have a acute MI on Celebrex is still there. So obviously, you're not going to put it in patients that are high risk for developing Celebrex. So, what kind of patients would you see on Celebrex? Patients that really need pain management for aggressive diseases like RA, rheumatoid arthritis, gout, some of those other conditions, which we'll talk about in the next couple hours. Excuse me, let me take a sip of coffee. We'll expand that mechanism in a minute. So the outcome here is, so why is aspirin cardioprotective while the COX-2 inhibitors are cardiotoxic? Remember I said aspirin has the ability to block both COX-1 and 2? Right? Aspirin inhibits thromboxane, we've established that. COX-2 has essentially no effect on thromboxane synthesis. All right? This is a cool series of animations I stole from Dr. Hendy. I didn't steal them, I asked him. I asked him after I put him in the lecture. I guess it's kind of stealing. So let's kind of review what we're talking about over here. So there's a nice balance between thinning blood and clotting blood. Thinning is driven by prostaglandin I2. Thromboxane is driving clotting. Okay, so normal physiology, there exists an equilibrium, correct? You supply aspirin, okay, which is going to inhibit prostaglandin I2 via COX-2 inhibition. You supply aspirin, which is going to inhibit thromboxane synthesis via COX-1 inhibition. Okay. And what happens? Prostaglandin increases. Wait. Yeah, sorry. Prostaglandin increases, which causes the equilibrium shift to thinning. Right? Why is that? Because aspirin inhibition is irreversible, but the endothelial cells, which remember is the source for the prostaglandins, over time they can produce more PGI2. Okay? Even in spite of aspirin therapy being continually on board. All right? And that's the outcome. We see patients that are maintained on long-term aspirin, even if they have increased prostaglandin activity, they still have inhibition of thromboxane, favoring a thinning mechanism or a thinning physiologic effect. Now remember, aspirin is going to bind to that COX-1 enzyme on the platelet for the entire life of the platelet, and that is not reversible, right? It's an irreversible binding, and platelets themselves cannot produce more thromboxane when inhibited by aspirin. So that push of the arrow to go from clotting to thinning stays in this direction. And that's how, over time, these patients are maintained with the use of aspirin. Okay? How about other NSAIDs? Okay? So here's, again, back to baseline, prostaglandin I2 and thromboxane working in opposite of each other, basically maintaining blood in a perfect environment that's neither too thin nor too clotted. You supply your NSAID, which blocks COX-2. You supply your NSAID, which blocks COX-1. All right? And there's no change in thinning or clotting. But that is irreversible. I'm sorry, inhibition is reversible. So the drug is stopped. Prostaglandin I2 and thromboxane are still made. Bless you. And there's no change, all right? And we see this, right? Patients that are maintained on ibuprofen or other NSAIDs, they're not known to have too thin or too thick blood, right? Because there's equal reversible inhibition of thromboxane and PGI2. Now, when you supply your COX-2 specific inhibitors, the balance shifts. Again, here's our baseline. Add COX-2 inhibitor. Dramatically reduce PGI2. No effect on thromboxanes. We shift that cascade to favor a clotting mechanism, right? And so when you give those COX-2 inhibitors like Vioxx, you can favor the production of STEMI because now you're producing blood that's hypercoagulated, right? Too thick. No inhibition, no effect of COX-1, no effect on thromboxane. All right? Does that make sense? For the people that are looking at home, I can copy this presentation as a PowerPoint and repost it because I was just thinking I posted it as a PDF and I don't think you'll see the animation on your PDF. So I can cut that portion of the presentation and post it this afternoon as a PowerPoint with the animations intact. Okay? If people found that helpful. So aspirin is different from the other COX-2 inhibitors. All right? So we said it acetylates COX-2. It inhibits prostaglandin production from arachidonic acid. Okay? And this is the nuance of this drug that was recently discovered. While we enhance COX-2-mediated production of the 15-epi-lipoxin from AA, what does that mean? So remember I said that aspirin has these anti-inflammatory components as well? We haven't really touched on that mechanism. Okay? This is kind of describing that mechanism. Let me pull this next presentation, or this next slide up. So C24, these are your PUFAs, your polyunsaturated fatty acids. Okay? And they can be converted into leukotrienes, they can be converted into lipoxins, and they can be converted into prostaglandins and thromboxanes. Now, if you give an NSAID, ibuprofen, ketoprofen, some of these others, they inhibit the production of prostaglandins and thromboxanes from these polyunsaturated fatty acids. If you give aspirin specifically, it converts these polyunsaturated fatty acids into what's called 15-epoxy or epi-lipoxins. And these compounds actually have potent anti-inflammatory capabilities that are just recently being unraveled. Right? And so this is a unique group of compounds that are essentially only produced in vivo when aspirin is on board. Okay, you wouldn't find these compounds in nature. At least nobody has yet. Maybe they're out there. And mechanistically, we've found that these compounds inhibit neutrophil adhesion and inhibit cell proliferation. And these are the supposed believed mechanisms that contribute to aspirin's anti-inflammatory activity. Okay. Now, another source of long-chain polyunsaturated fatty acids, where's the thing, are the omega-3 fatty acids, right? And lo and behold, remember, maybe it was about 10 years ago, there was a clinical trial that said fish oil combined with aspirin in post-STEMI patients offered a therapeutic benefit to their success on therapy. This is maybe the scientific reasoning behind that. Okay, because now these polyunsaturated fatty acids are a base for the production of these compounds that I just described in the previous slide that contribute to the anti-inflammatory effects of aspirin independent of the anti-platelet effects you're all familiar with. And there's another mechanism that I don't want to get into at this point, but resolvin, E1, has been shown to be enhanced by aspirin, acetylation of the COX-2 enzyme. And in vivo models, it's been shown to dramatically reduce leukocyte infiltration. So here aspirin is acting as an immune suppressant, right? If you reduce immune cell infiltration, it's acting as a classic immunosuppressant. So there's all these mechanisms that are coming out of the woodwork with this very, very old and very simple drug. Okay? So it's pretty interesting. Now understand that, we've been talking about Nsaids as having the ability to be COX-1 specific, non-specific, binding to either COX-1 or 2, and COX-2 specific. Okay? So this is just kind of a nice summary chart comparing the relative sensitivities or selectivities of all these different NSAIDs with regarding COX-1 and COX-2. So the COX-1 specific drugs are on this side of the diagram, and your COX-2 specific drugs are on this side of the diagram. That's not a bad two. Okay. And understand here, aspirin's right here. Aspirin is slightly more COX-2 selective than COX-1. Okay, but we talked about the difference in dosage. So you can shift this curve of where aspirin falls depending on the dose. So a high dose aspirin will be more COX-2 specific, and a low dose aspirin will be a little bit more COX-1 specific. I know it's confusing. That's why just don't even look at the, oops, sorry, don't even look at the axis. Just focus here. I'm not going to ask you which one's more selective, but this is just kind of FYI, because we talk about them as continuum. So if you look at the indications for certain drugs, you can kind of judge which indication would be matching the COX-2 pathway versus which indication would be matching the COX-1 pathway. Okay? Yeah, I mean, if it's, I know it's kind of hard to read. It took me a couple times to read it too before I started to get it, but I'm not gonna, if it's not helping you, ignore it. If it's helping you, then fine. Okay. I don't want to make your life more difficult. All right? Yeah. So don't expect a blank diagram on the exam and say which of the following is this. I don't know. Who cares? Okay. So let's quickly summarize. Aspirin inhibits the early phase response to inflammation, and essentially we're inhibiting the prostaglandin thromboxane activity via COX-1 or 2. And then we've also shown that it enhances the resolution phase. So the resolution phase of inflammation is your anti-inflammatory cascade. And that's that mechanism of the 15-epi-lipoxin from arachidonic acid. The COX-2 inhibitors essentially inhibit the early response to inflammation via COX-2. And they have essentially no thromboxane activity. We saw that in the cartoon. Okay. So how about looking at some of the non-selective NSAIDs? Remember, none of these drugs essentially cure the underlying condition. They all have some degree of analgesic, antipyretic, and anti-inflammatory effects. All right? We typically classify these drugs by chemical structure. So there's a structure-activity relationship between all those different COX inhibitors. And what most people do is they start a patient on one of the drug classes, and if it doesn't work, they just change them to a different drug class. And what are those drug classes? Well, essentially there's three. Carboxylic acids are your aspirin and aspirin-like compounds. Propionic acids are your ibuprofen or Motrin and naproxen-like compounds. And acetic acid derivatives are your indomethacin and diclofenac-like compounds. Okay, so these all have different chemical structures. So if somebody's taking ibuprofen and it's not doing the job, you can switch them to either indomethacin or aspirin and see if their pain, fever, or inflammation can be controlled through that different drug class. So lots of different clinical uses of NSAIDs. We'll talk about rheumatoid arthritis. Pretty much all these drugs except ketorolac can be used for RA. When we talk about mild to moderate pain, anything except indomethacin, Sulindac, or piroxicam can be used. Moderate to severe pain, ketorolac is really good, but you have to limit it to five pills. Primary dysmenorrhea, ibuprofen, ketoprofen, naproxen. All these are relatively good for dysmenorrhea equally. Here's kind of a nice summary slide of the different NSAIDs and notes about them. Understand that something like indomethacin would be excellent for pain management, but not really good for patients that are experiencing acute renal failure. Other drugs are not really well indicated for pain, but are excellent for something like inflammation or fever. All right? So, there's no real hard and fast rule for which drug class is better than the other, which is why when you go into the OTC pain section at your local pharmacy, I mean, how long is that aisle, right? And then there's all these different formulations of extended release and sustained release and tablets, gel caps, chewables. I mean, it's a huge market. And so, and a lot of it's really just on the patient side. It's really just guess and check because people are self-medicating for a strain, a sprain, in my case, a slipped disc. I just went to Midwest Orthopedics, and I've been limping around for like 4 months, and they just diagnosed I have a slipped disc. I'm like, great, that's good. So they gave me the Medrol, medroxyprogesterone, methylprednisone. Yeah, they gave me yeah, they gave me medroxyprogesterone. Oh God, we can do so many jokes there, but I'll get in trouble. No, they gave me methylprednisone, and so I'm on like high-dose glucocorticoids, and I'm loving it right now. This is great. I don't even feel my back, but so what are the side effects for these drugs? You've got GI ulceration. You can give something like misoprostol, which is a PGE1 analog. You can also give Prilosec to kind of combat that irritated GI tract. In terms of inhibition, there's also PGE2 and PGE1. Both of them are vasodilatory. And then there's indications if there's altered renal physiology there as well. Oh, what's that? Oh, I forgot Arthro. So yeah, Arthrotec, which is, that scared me. I forgot that was in there. Arthrotec contains diclofenac and misoprostol. So it's a dual regimen type of compound that you can use for some of those patients. I didn't even know we had sound on this. This is creepy. I hope there's no other ones. So yeah, tons of renal side effects. Some of these drugs have little to no side effects in terms of the kidney function, like Sulindac, and others are associated with acute renal failure, like indomethacin. Okay, so obviously it's good to take an important patient history. Other side effects include, obviously, inhibition of platelet aggregation. When we talk about aspirin and platelet aggregation, I mean, that's the clinical benefit of it. Obviously, if you don't want to have your platelets aggregated, obviously that's a side effect in a non-STEMI patient. We can also alter uterine motility, and there are hypersensitivity reactions, as I mentioned earlier, most commonly encountered with aspirin, but some people have been known to be allergic to other Nsaids as well. Okay? So acetaminophen. I alluded earlier that you've got your gel caps, you've got your melt-aways, you've got your oral suspensions, and look at this, children's Tylenol. Ages 2 to 11, infant drops. Why would you give kids Tylenol? Any ideas? Why would you give infants Tylenol? What's that? You can give it to them after vaccinations if they have a fever, right? What else do kids do all the time? They get sick. And when they get sick, they get fevers. And if you go into pediatrics, that's the number one thing parents are aggravated about. My kid has a fever. So they think anything over 98 is, the kid's going to boil. Remember, fevers are good, right? Because that is a sign and symptom for you to tell you that there's an infection. But parents hate fevers. And so these things are, out there. And if the kid goes over 98 Fahrenheit, they are getting acetaminophen, right? Other indications for Tylenol with infants include teething, right? So a 3-month-old, 4-month-old will start teething. That's an inflammatory response. Body temperature goes up, inflammation, pain, okay? And, it's a baby, and so they can't talk about it. So what do? They cry, make everybody upset. Okay, so children's Tylenol post-vaccination. And what else do kids do? They hurt themselves. They bruise themselves. So, lots of indications for acetaminophen in young people, old people. Who else takes a lot of Tylenol? College students. Why do they take Tylenol? Post-drinking, right? And we'll talk about that in a minute, too. So acetaminophen is used for many conditions: headache, muscle aches, arthritis, backache, toothaches, colds, fevers. All right? There's formulations for pretty much everybody out there. You can even see Tylenol being used in preterm neonates. We have dosing guidelines for preterm neonates. Okay? So adults, for people that are going to go to family medicine, you probably will need to know this. I'm not going to ask you this stuff for this exam, but I think you have enough to worry about. But this is kind of a nice thing to keep handy because, you know, you will at some point be asked to calculate this for your patients. So the adult dose can be as low as 25 milligrams to as high as 650 milligrams every 4 to 6 hours. Infants and children under 12, 10 milligrams per kilogram per dose every 4 to 6 hours, not to exceed 5 doses in one day. Children over 12 years of age can be 300 to 600 milligrams every 4 to 6 hours. You know, so we've got dosing guidelines for pretty much everybody, because at some point, pretty much everybody's going to need Tylenol. All right. Here's the pediatric acetaminophen dosing guidelines. This was copied from Up to Date, which was updated, I think, last year. So I don't think these have changed much. You can do it by weight. Where's the mouse? You can do it by weight, which is more accurate, or you can do it by age, which is less accurate. So, you know, assuming the parents can weigh the kid, you would think that that's not an issue, but it is. You can quickly calculate the amount of drug that they need for pain, fever, inflammation, and so forth. So, know your drugs. So remember I said the OTC section at your Walgreens is just inundated with all kinds of these drug regimens? Well, remember that there's a lot of need to have one bottle that has 3 or 4 drugs in it, right? So think of like Dayquil, NyQuil, Triaminic, right? There's 3 or 4 drugs in that one bottle. And a lot of these can contain acetaminophen. And actually the ones on the left are the OTC medications that are known to contain acetaminophen. There are prescription drugs that contain high doses of acetaminophen. You've heard of Vicodin, Tylenol number 3, Loratab, Norco. There's acetaminophen in there. So what does that mean? Well, imagine this. Imagine you've got a patient who had a root canal. All right, so the doctor prescribed them, 800 milligrams of acetaminophen, or maybe gave them a small amount of Vicodin, okay? And then they get sick, so they start taking Dayquil. They don't realize that Dayquil has acetaminophen. They develop a fever, so they take even more acetaminophen in a separate bottle. So there's potentially 3 drugs that they've taken in one day that has acetaminophen. So what does that mean? They can become toxic very quickly. You know, so this is one of the deleterious parts of combining OTC medications and these formulations that are extremely convenient for the patients, but can be problematic, especially if the patient's ill-informed. All right. So what does that lead to? Well, it leads to acetaminophen toxicity. So under normal conditions, acetaminophen becomes conjugated into a sulfate moiety that is non-toxic, a glucuronide moiety, which is non-toxic. Both of these are through conjugation reactions. But there is one metabolic pathway that's CYP2E1 specific that converts acetaminophen into NAPQI, which is the chemical formula shown here, and that is hepatotoxic. All right. It becomes hepatotoxic when glutathione reserves have been reduced, because glutathione can actually detoxify this NAPQI compound into cysteine conjugates. When glutathione reserves are depleted for different reasons, pathology, variability within the patient's genetics, these NAPQI products can accumulate and cause extensive hepatic damage. You know, so one of the ways we can alleviate that is we can supply N-acetylcysteine, which is NAC, and that is a glutathione stimulator, which can actually drive the detoxification of NAPQI into its cysteine conjugates. Okay, but this assumes one thing. that you know the patient took acetaminophen at high doses, right? So, you know, ER physicians see this all the time. You know, what kind of patients present to the emergency room with acetaminophen toxicity? Well, patients that want to commit suicide. Do you think they're going to tell you that they took a lot of acetaminophen if their immediate goal is suicide? Maybe not. Some people take too many pills for immediate relief. You know, there are people out there who think, oh, 60 milligrams of vitamin C is good for you, so if I take 6,000 milligrams of vitamin C, I won't catch the flu, right? So those same people are the ones who will take a whole bottle of acetaminophen because their head hurts. Okay? College students go out drinking. Drinking depletes glutathione naturally. And when they have their hangover the next morning, they just take 3 or 4 or 5 or 6 acetaminophen, and all of a sudden they've got the production of these hepatotoxic metabolites in their liver. Right? So, you know, there's different clinical indications for where acetaminophen can become toxic, and it can be toxic very quickly. So, you know, the sooner you can figure this out and the sooner you can administer N-acetylcysteine, the faster you can convert this toxic metabolite into its non-toxic form and save the liver. All right, let's take a break there, and we'll start with rheumatoid arthritis. If you have any questions on Nsaids, we can address those or take a few-minute break.